First off, I'd like to thank Sharon for asking me to talk today about one of my favourite topics. So there is Level 1 Grade A evidence defined according to the National Health and Medical Research criteria that attendance at cardiovascular disease secondary prevention and cardiac rehabilitation after a cardiac event decreases morbidity and mortality and improves quality of life. The definition of cardiac rehabilitation is it's defined as the sum of activities provided for people with or at high risk of heart disease to support them to understand their disease, its treatment and the behaviours required to improve both physical and psychological health. Cardiac rehab incorporates all types of heart disease regardless of acuity. And the patient should be situated at the centre of the care decisions with support and resources from health professionals. The summary of core components, and this is a paper that was released last year from the Australian Cardiovascular Health and Cardiac Rehab Association. All eligible patients must be offered referral to a cardiac rehab service which best suits their individual needs as soon as possible after diagnosis or before discharge from hospital, and it should include referral to a GP for long-term care. All eligible cardiac patients should receive an individualised initial assessment that includes physical, psychological and social parameters with referral on to appropriate services based on patient needs, followed by ongoing review, discharge assessment and follow-up. The services should facilitate patients' return to or to improve on baseline everyday functioning, including employment, driving, resumption of sexual activity and other activities of daily living, and help them maintain these lifelong. When the cardiac condition or other comorbidities preclude this, the service should focus on maximising potential and providing coping strategies. Services should be tailored to provide education and skill development to motivate and enable patients to self-care and to make changes in their lifestyle to address their multiple risk factors and to ensure adherence to prescribed medications. And all services should collect a minimum data set. Cardiac patients have complex social, physical and spiritual needs, and skilled cardiac rehab professionals can facilitate recovery, identify healthcare needs, changes in health status and prevent deterioration in condition. Many patients will have comorbid illnesses, and cardiac rehab professionals need sufficient knowledge and expertise to manage these. The professionals must be able to demonstrate ongoing professional development in areas of relevance to their role. And the cardiac rehab team can comprise of many from the allied health services. A pre-program assessment attended on the cardiac patient will include a physical assessment, a psychosocial assessment, risk factor assessment, health knowledge assessment, screening for anxiety and depression, a medication review, an exercise history, a functional capacity test either via stress testing or 6-minute walk test, a medical history, symptom recognition and self-management assessment. There will be goal setting with the patient for risk factor management using health coaching and motivational interviewing. There will be relevant education topics assessed for each patient. There will be a home exercise prescription. There will be an explanation about the program and the patient's responsibilities, and we will include all significant others. The program is usually individually prescribed exercise based on the 6-minute walk test or exercise test, the exercise history and the diagnosis, and we do a risk stratification as well. It can be site-based or home-based, and each patient is reviewed prior to each exercise class for symptoms, home activities progression, medication compliance and their home exercise progression. The patient's site-based exercise is progressed according to exercise prescription guidelines locally, risk stratification, heart rates, and we use the Borg scale. The patient's response to exercise is assessed and reviewed at each session, and exercise prescription is progressed according to local protocols. And any adverse effects during the exercise classes, consultation can occur with the registrar, the GP or the physician. The home-based exercise is progressed depending on what the patient is actually doing at home. The education and discussion sessions use adult learning principles, and the patient chooses which sessions they want to attend. We include the family, the spouse or the partners, and individual exercise and counselling is given and as required at each interface with each patient. During the patient's program, the patient can request to be referred to or be referred by the program staff to any other allied health team they require. The patient's not discharged from the program until they can till they have the knowledge to self-manage. It used to be a straight 6-week program, kaput, finished, off you go, but that's no longer the case. Some patients need a 4-week program, some patients need a 4-month program. It just depends on the individual and what they're capable of and their pre-morbid state. At the post-program assessment, we do a symptom-limited stress test or 6-minute walk test to assess improvement in functional capacity, assess their sign and symptom response to exercise. We do another risk factor assessment and look at the goals that they have achieved, and we reset goals for the future. We don't reset them, the patient does. We look at how they're returning to their normal activities, but this will have been looked at all through the patient's program. We do another psychosocial assessment, and we prepare a report and forward that to the GP and the physician. In the valve patient in particular, what are we looking for in cardiac rehabilitation? As for any other patient attending our program, we look at maladaptation and or problems and psychological issues that need to be ongoing addressed. We look at poor health choices, and that's a very complex issue and another topic all on its own about how we go about addressing that. We look at wound issues. Luckily, they're few and far between these days. We look at medication compliance and side effects. Are the patients taking their medications? Did they think when their scripts ran out that they could stop taking them? Does their medications match their discharge summary, which unfortunately often they don't, and we have to sort those issues out. We look at whether they're following up with their surgeon and their cardiologist, and we really hammer that home how important that is and make sure they've got appointments. We look at their return to their usual activities and if there's any issues revolving around that. And we make sure that they're well aware of correct symptom recognition and action to take if there's problems. Specifically in the valve patient, we're looking for signs of arrhythmias, particularly atrial arrhythmias. We pick up a lot of atrial fibrillation in cardiac rehabilitation. We look for signs of heart failure each time the patient visits. We look at whether they're having high resting and exercise heart rates without arrhythmia, and we make sure that the patient, if they're on warfarin, are getting their INRs checked and that they're in the parameters that have been prescribed for the individual patient. So you can see that it's quite complex. It's a hard topic to talk about in 10 minutes, but I've given you a very brief overview today of how involved cardiac rehabilitation is. Thank you.